Ladies and gentlemen, good evening and welcome to this training session on the male patient in aesthetic medicine. It's all about masculinization. Here we are this evening with our expert, Dr. Fabien Giausseran. How are you this evening?
All good.
Fantastic. Thank you very much for being with us. Now, while he's here with us, he'll be showing us a number of techniques and some products. If you have any questions that you would like to ask, please do send them in via the live chat and we will answer them as best we can. So without any further ado, I actually do have a first question that I would like to ask you. What can you say about the male market when it comes to aesthetic medicine?
So it's become bigger and bigger. I want to say thank you to Filmed to give the opportunity to share knowledge tonight. Really thank you, and thank you to all my colleagues all over the world, Europe. You're really welcome. So please be active, send all the questions, send the feedback. We will share together this night. So yeah, Peter, that's true. This webinar is really true in the aesthetic procedure because on the global market, it's about 8%, maximum 10% about male patients, they came to the clinics. So we need a specific approach, a specific protocols to answer to this demand. So we need to dedicate a specific consultation. And what about the procedures? The procedures, it's I'm thinking about the static reports of the American Plastic Surgery Society. And what they say from the last 20 years, it's becoming huge and huge about the surgery, but also in the soft cosmetic procedures. It's about the fillers, it's about toxin, the dermabrasion, the chemical pills. So it's become really bigger and bigger, more than 100% in plus in the ocrazing. So it's really huge.
Okay, and what is specific to treating male patients as opposed to female patients?
So right, good question, Peter. Yeah. So the demand is totally different and the context is different. It's all about the social approach and more professionals. They want to refresh the face, and with our patient Pierre tonight, we were talking of before, and he said to me, I don't want a surgical look, I don't want a big face, I don't want to become female, I don't want big cheekbones. So what about the specificity anatomical? It's about the skin, the bones, the muscle. Of course, the skin is all about the hormone, testosterone, so the glands are bigger, the skin is thicker, and there's high vascularization. What about the bones? The fat part, the fat compartment are smaller, the chin is stronger, the jawline is strong, and we have more definition about the verticality. And when we are talking about another a protocol that we will talking later, biometry shape for the male patient, we are talking about verticality more than horizontality. And muscle, of course, they are bigger. So to understand the masculine facial shape, I like to approach step by step, upper compartment, a mid face, and the lower face. So what about the forehead? Forehead, of course, we can talk about the toxin, but we can talk about fillers too, and we will see with the blanching technique. What about the regard? And it's a good demands on the patient tonight. He wants to enhance the regard. And what about the glabella? The glabella is larger. Then we go to the mid-face. Mid-face, cheekbones. Cheekbones are lower and more horizontal. And what about the cheek too? Fat pad compartment are smaller and the development of the muscle are bigger. So then we go to the lower part, my favorite part to inject male patient, and we will see with Pierre. What about the mandibular bone? They are prominent, they are strong. You can give strong definition on the chin and on the masseter.
Okay, so you were just talking about the specificities of male patients.
Yeah.
But what are the main requests that you get from male patients? What do they ask for the most often?
Yeah. The demands is all about the regard and the smile. But it's quite similar with the women patients. So we want to enhance the regard and we want to enhance the smile. So what men want, I like and I appreciate the approach of my great friend, Dr. Frédéric Braccini, plastic surgeon in Nice. in France is talking about less is more, and in the male patient is really appreciated because we want to inject small quantity of a good product on the good place to enhance what? To enhance the masculinization of the face. So we will more inject about the metaface, less in the mesoface, and a little bit to do the profiloplasty on the proface. So this is really the approach about the male patient.
Okay, so you were talking about how it's all about masculinization and less is more. But what techniques and what products do you use to achieve that result?
Yeah, you're right. This is a good question too, because we need the right products on the right quantity, on the good layer, on a good plan with the appropriate techniques. So what about the technique? I think we can see on the next slide what it's about. The chin. The chin, I need a volumizing filler. So I will do two bully, each part of the ventalis. With the cannula, with the needle, we will do a needle approach. Then, what about the tear through and the regard? I need a medium elastic filler. So my favorite fillers in this case will be the fine lines with less hydrophilia, but you can use it to outfiller universal. You have to go on the soup, contact to the bone, on the soup under the all the fat pad, and you go slide the cannula on the periosteum with the cannula. Minimum 25 gauge. Remember, it's dangerous to use a 30 on a 27 gauge. So this is about the tear through, and we'll see a specific approach on Pierre about the ORL and how to erase the holo and to give the light on the regard. Then my favorite approach to the male lower part, mandibular line and masseter. On the mandibular line, I need a volumizing filler or a medium elastic filler. So in this case, we can use it universal or volume. So we will use it the volume to do good pillars, and I will use the plasticity of the outfiller volumes to reshape and to amplified the masseter, and then I will spread on the superficial layer with the universal, with the cannula, 25 gauge cannula, and I will spread the universal. So I can use and I can mix the products because of the good cohesivity of my products. So this is really important. When I use a filler, I really appreciate the cohesivity, the elasticity, and the plasticity. And in the male patient, to achieve a natural result, you need to have a good plasticity, modelability of the product. You need an elastic product to give projection under all these muscles and all the fat pad, the strong muscle, but you need a good cohesivity when you go superficial just to do gentle details.
Okay, so is there a specific actually shape or technique that you use when you're working down the face?
Yeah, so we develop with film at laboratories the bionutri shape, and please let me introduce you. As my dear colleague Valérie Philippon from Boulogne-Billancourt did it last month about the nanosoft technology. We have nanosoft to enhance the regard. So I know my male patient prefer to have a one-shot procedures, but in 3 sessions, each 3 weeks, we can achieve a good result to give more elasticity and to erase the fine lines under the lower eyelid. And this is really important to use and to optimize your NCTF 135HA with the nanosoft technology. We will see on the patient directly.
Okay, well, in that case, I think without any further ado, I should let you get to work. And everyone who's watching, if you do have any questions, please do send them in, because throughout this evening's procedures, we will be able to ask them of our doctor. So keep sending them in, and I'll be back a little later. So, doctor, over to you.
Okay, thank you, Peter. Maybe you can sit down, Pierre. So we will do the analysis, because this is the most important time when we do the procedure. So Pierre is 40 years old, and he never did an aesthetic procedure. So he came to the clinic and he said, okay, I want to refresh my face. I want to have a natural effect, and I don't want to be a volumizing cheekbones, right, Pierre? Okay, so what we see on the upper part, on the medium part, and on the lower part. So, of course, on this patient, fronce fort, 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 and surélève. So we see a normal kinetic patient for the forehead and for the frontalis and the corrugator, but of course this patient is a good indication to the toxin. Then, if if it doesn't want to have this injection, or after 2 or 4 weeks, we can do a little blanching technique with my art filler fine lines, and we will see how to erase all the fine lines with my fine lines. Okay. Then we see the temples. Temples are normal temples, so I don't want to inject the temples in this patient. Then I want to enhance the regard. So how to say? Souris fort, fort, fort. Relax. There is no malar fat bag, so this is okay. I see a little molar groove, and I want to avoid the segmentation of the medial fat pad in the medial part and in the lateral part. So you see there is a beginning of the segmentation between the orbicularis ear, the orbicularis ear, and the beginning of the tear throat. So I want to have a solution not to amplify the apex of the malar, but I want to erase the shadow. So I will do an entry point here with the cannula. I will use universal or fine lines in this patient because of the thinness of the skin. I will prefer fine lines, less hydrophilia, and I will inject under the ORL, and I will inject some fillers in this position. I will feel the double click, and I will erase the shadow on this part. But I don't want to amplify the cheekbones. Okay? So this is the most important. And of course, with the nanosoft technology, with the fine papule, I can improve the skin quality and the fine lines here on the lower eyelid. So I will do the first session, and he will come to my clinic after 1 month and another month. So this is the good solution. After, what we see the lower part. What about the profiloplasty? Profiloplasty is not too bad because we have already good angles, good projection, but I think to avoid the bones resorptions and to give more a strong definition of the profile, I will inject few boli, so 2 boli each part of the mentalis with my art fillers volume 0.2, maximum 0.4, in order to give a good shape and to restore the projection and to amplify a little bit the chin. And what about, of course, this part, the masseter? Alors, fais comme ça un peu, Pierre. Yeah, I feel it. You feel the triangular muscles. And in this part, I will inject 3 boli with my art filler volume, deep into the muscles to amplify the masseter. And then, just 1 centimeter before the angle of the mandibular, I will inject in a superficial layer the art filler universal in order to spread and to, in the way of the bionutri shape, in the male bionutri shape, I will maybe mix the universal with the NCTF to give more definition and masculinize the profile. And of course, you don't see on the video, but I need to enhance the laxity of the skin. So this protocol and this angle and this protocol, we give a good support and avoid the sagging in the next 10 years in the patient. And if we have time, maybe we will see in another technique, maybe with the needle or with the cannula approach, with the fine lines, how to erase this shadow and how to erase the little beginning of the sagging of the corner of the mouth. Okay, I hope you agree with this assessment, and let's do it. If you have any question, please, you're welcome.
Okay, so we are actually getting a lot of questions coming in.
Yeah.
We are trying to sort through them all, and we will be able to ask you a couple in just a few moments once we have a good section of questions all ready to ask for you. But do keep on sending them in, and we will have some. I can see them coming up on my screen right now, so we'll keep on asking them in a little moment. So keep on sending them in, and back shortly.
Okay, so now I will begin with my art filler volume with the 27 gauge needle, and I will do the amplification and the restoration of the mentalis. So I pinch my mentalis, and each part I will do contact to the bones. 1, 2, je pique. Okay, and I go not totally contact to the periosteum, but I just stop 1 millimeter before. Depends of the length of the chin of your patient, but sometimes even with the 14 millimeters length of your needles, you don't go contact to the periosteum, but you are into the mentalis. I inject slowly the volumizing fillers, the art filler volume. Why? The slower I am, the safer I am, less bruising, less edema, less hematoma. So in this case, I will inject a bolus of 0.3 volume. Okay, you see sometimes, even if I have a good support on the chest of the patient and with my opposite hand, you see my needle moving. Why? Because of the projection of the elasticity of the product. Ça va, Pierre? Sens quelque chose? Okay, so it's penless, and it's very important on our male patient. They need a penless procedure because this is one of the fourth indication that the patients say, I don't want any more an aesthetic procedure, especially in the male patient. They want a penless procedure, they want a long-lasting result, they want a safe and secure procedure, and they want naturality, not a surgical phase. So only with the 0.3 bolus, I see the projection of the chin and it gives a good support. Maybe we can see, if you sit down, you see really the volumizing power of the art filler volume. So you see now on the profile the good projection, and I see, and look at the opposite. Now you see that we need to inject a little bit to give a stronger position. And what about the chin angle and the chin line? It's better on this profile. Look at the chin line.
Excuse me, doctor, could I just interrupt for one quick second?
Definitely, yeah.
Yes, we have a question here from Dr. Smith from South Africa. Thank you very much. And the question is actually in relation to the lower part of the face.
Hi, Ricky. I think it's Ricky. Hi.
So the question is, why did you start with the lower part of the face and not at the middle or the top?
But because I want to impact you on my favorite procedure, and in a male patient, it's all about the lower face and the metaface. I called it teloface before, but I did a mistake. It's a teloface. It's a metaface. So I want to impact you on the procedure. The most impressive procedure is the lower face. And if the patient come to your clinic and if they need just refresh my face and you have only 2 syringes to inject because of the budget, because of the timing, because of the downtime, you have to begin by the lower face. Okay. Excellent question, Ricky.
And we also have another question. This one is not from South Africa. It's all the way from Russia.
Yeah.
So we're going to another continent here. And the question is, what is the injection plan for the chin?
For the chin, I told you, I go to the periosteum, so contact to the periosteum. But even if I'm at the end of the mentalis, it's okay if I inject. So I inject into the mentalis or contact to the periosteum. I go through the maximum length of my needle, the 27 needle that it's contained in the box of the art filler volume.
Okay, fantastic. Well, I'll come back in a few short moments if we get any more questions for you.
Yeah,
fantastic.
I do in the same time as the opposite, but maybe I will do a split face. But okay, the chin is down. So, tu as senti quelque chose? So this is painless procedure. So now we will do the amplification of the masseter. Masseter, and because this is my second syringe. So what about the quantity? 0.3, 0.3.
Okay, just another quick question, seeing as we are talking about the chin area. We've still got another question. This one is from Javier from Spain. Thank you again for your question.
I think it's Javier Beut. Hello, Javier.
And this question is, what are the risks involved with injecting in the chin area?
Or the chin area, I use with my needle, so it's a safer area. You got the mentalis arteria, but it's more if you inject this fold, the fold between the lower lips and the chin. If you inject this part, you have to use it normally a cannula. But if you go on this part, it's okay if you go to the periosteum. So the risk is minimum. Really is a safer part. So now I will do my body.
Okay.
My body to do the amplification of the masseter. Okay? So, contracte un petit peu.
I'll be back in just 1 second with more questions.
Yeah. Thank you, Peter. So, I do my first relax, and I will inject into the masseter. So look, in this area, I do the retro aspiration. And I'll look at the, okay, retro aspiration negative, and I will inject a bolus of 0.3. So I propose to use a minimal approach or a realistic approach as same in my clinic. So I will use half a syringe to do the amplification. So I will inject 3 bolli of 0.2 product of heart filler. So I inject into the muscle. Voilà. Okay, so I continue. Ouais, relax. Ouais. I inject slower, and what I want to do, I want to amplify the masseter, the volume, and to give a masculinized look, but not too much. J'ai pas compris. Ah, okay. Sorry, I didn't see. Okay.
Sorry, Fabien. And just while you're on that, we do have a question from Colombia. And this one is, if you could just go over the injection plan just once again, so that we can get that right.
Repeat, Peter, please.
So the injection plan for the chin. This is a question from Colombia.
Ah, but
Thank you very much for your question.
this is the same from Russia. Periosteum.
Yeah, so if we could, and also for the masseter. So if we go over
Masseter,
the,
I do into the muscles, because this is the big muscle. So I'm into the muscle. I'm into the muscle for the masseter. Okay, I don't go contact. It's impossible, or the masseter will be really 0.
And just why not against the bone? This is a question from Mexico, actually. So why not into the bone or near the bone?
To do what? The masseter?
Mm.
But because I see, because of the integration of my product, I have a long-lasting result into the muscles, and I do an economical approach in the muscles. I inject less product in the muscles, and I have a good shape in the muscles, and I can immediately do the plasticity of the product and look. I do immediately look at the camera. Immediately after my bolus, I do my triangulation. I do the shaping of what I want to do. So now I will finish in a second layer to do the amplification of the masseter with the universal.
Okay, well, I will just leave you here once again. Keep on sending those questions in. As you can see, we have them coming in, and we will continue to ask them. So I'll be back soon.
Yeah, so now I will do with an entry point with the cannula approach. With the, I prefer the TSK, but you can use it, the Filmed cannula too. It depends of your approach. What I will do the approach to amplify the masseter. So where is my entry point? My entry point is here. Where will be my entry point? My entry point will be just 1 centimeter before or devant, behind the angle of the masseter, the angle of the mandible. So look, my angle of the mandible is here, my bone is here, so I will pinch and do your entry point. Ça va, Pierre? Super. So painless procedure right now. Which product I choose? I choose universal. Why universal? Because look, stretch the skin with your opposite hand, rotate the body of your syringe, and go. Of course, you are on the hypodermis, but I want to spread more superficial to do a good shape. So let's have a normal and a realistic approach. So I will spread only 0.6. I repeat, in my art filler universal, I've got 1.2 and not 1.0. And this 0.2 in plus sometimes do the difference on the patient. Remember the less is more approach. It's okay for the female patient, or it's okay for the lips or the regard. But in the male patient, in the metaphase, in the masseter, in the chin, is the opposite. You can inject to do a good and a strong definition. So what I do a fanning technique, stretch the skin, rotate if you feel the fibrosis, or is not at all the fibrosis, is more all the septi. I broke all the septi between the fat loge, the fat compartment. And I do 0.5, maximum 0.1 retrotracing fanning technique. So yeah.
Sorry, could I just interrupt for a quick second? I have a question here for you.
Yeah, listening.
So we had a question earlier on about the risks with the chin. Now we have a question from Dr. Alguilar from Mexico. So thank you very much for your question. And he wants to know what the risks are when it comes to the masseter.
Into the masseter, you know, parotidis glands is deeper. You've got the facial nerves, the 7 nerves, is really deep. So nerves, it's okay. Glands, it's okay. Veins, you have sometimes, but it's a few. And the more important, the arterial risk. What about the arteria? The arteria is really deep and is really not on this part. So this part is really safe for me. This part is really safe. The more dangerous part will be when we rejuvenate the regard. So here it's okay.
Okay, and we also have another question still on the masseter, and this is from Dr. Bern from Austria. So we're moving all around the world here. And this question is, why are you injecting volume and not universal into the masseter?
Because this is the male patient, and I want to give a strong definition. I want to amplify. Remember, what is about the aesthetic medicine and the aesthetic dermatology? It's about beautification. So now we do the beautification of Pierre. We do the beautification, and I want not to restore, because he didn't have this masseter, but I want to do an amplification, not to change the face, but just to give a little details. And with the universal, to support all the muscle pad will be not enough.
Okay, thank you very much. And there you have it, Dr. Byrne. There's your answer to that question. If you have any more questions, keep sending them in, and I'll be back later. Thank you very much.
Peter. So now when you do the question, look what I did. I use 1 vial of NCTF 135HA, and I spread it. So I use 1 vial of NCTF, and I spread it in the same layer when I did the universal, and I spread it in a way of the bionutri male shape, to restore and to enhance the extracellular matrix, to boost the fibroblast and to give the signal to my fibroblast, hey, you're sleepy, so you have to wake up and to produce elastin and fibroblast. So with the NCTF, I maximize my products, and this is the first step of the bionutri shape. And finally, this is the first station of the biorevitalization. So this is really important, even if the patient will not do as a female patient 5 sessions, but it's always a good option to do biorevitalization when we do volumizing session. So now we did the chin, we did the masseter, we did in a deep plans into the muscles volume 0.2, 0.2, 0.2. We spread it in the superficial layer, the universal retrotracing, and the NCTF 135HA. Now what we can do a needle approach for the marionette lines, really few. And now this is more the 2.4 protocols. 2.4 protocols from my friend Frédéric Braccini. Universal. With a needle approach. Let's see. So now, to avoid the contraction of all the muscle strength, you can just ask to your patient, ouvre un petit peu la bouche, open the mouth to avoid the modulus contraction. My entry point, 1 centimeter here, you pinch, and you go superficial. You can do an anterograde injection. You can do an anterograde. See the product, how we spread it. You see it? See it, it's spread it, but with the cohesivity of the product, I will spread it and I will modulable immediately after. Okay, I needed a little bit more. This is a soft approach because I don't want to inject the border of the wet lips, but I just want to restore the modulus. Another technique, go 1 centimeter, go perpendicular, 18 degrees, and do a bolus 0.05. What? This is the technique of the Mona Lisa lift smile, you know, to make horizontal the commissure.
Okay, I have a quick question here. In fact, I've got a number of questions, so we'll take them one after the other. The first one is from Doha in Qatar, and the question is, why not introduce the cannula from the anterior border of the muscle?
Repeat, why not to
So
use?
why don't you introduce the cannula from the anterior border?
For the interior what?
Anterior. Anterior. The rear border of the
Dis-moi en
muscle.
français.
Pourquoi ne pas introduire le canular depuis
Le bord interne? Le bord interne.
antérieur?
When we do the
Anterior.
masseter? But I didn't... okay. Because I say to you 1 centimeter devant, before the angles.
Exactly.
Because this is the male
right.
patient, this is the difference with the male patient. I want to amplify and to give a structure. So I can give angles when he will catch the light. Look, sit down. Look at this. Look, this is why we do the masculinization. Wow. You see, but of course you have the NCTF and the liquid. And I want to give and catch the light on this point. If I inject my border if I inject here, it will just do an anchorage. It will be okay for the jawline. It's a perfect point for the female patient, but it will don't give me the final touch to the masculinized patient. And look on the face from the face. Look, we really reshape the mandibular line. We do the projection. Each part of the mentalis we done, but this part, look the sagness, look the lack of the definition, look of the lack of the border and the angle. This is really the purpose of the male patient. And Ricky, this is your answer. Why I begin by the lower part? Because in this, I use it how many? Maybe 2 syringes and 0.3. I achieve the result with the chin, with the corner of the mouth, and of course with the masseter and all the angle.
And actually, while you're talking about the masseter there, we have a question from Mexico, and it's in relation to transgender men. So when you're working on the masseter, do you prefer to use volume to do masculinization or universal? Volume
each time, even if the skin is thin, in the case of Pierre, I use volume. Combien me reste de temps?
We've got about 25 minutes left, so keep on sending in those questions.
So I have time. Yes, we can do all the anatomical approach.
Exactly. Could I just ask you another quick question?
Yeah.
Yeah? Okay. So this one is about the size of the cannula, and can you use different sizes?
Of the cannula?
Of the cannula.
That's a good question. We're talking about that with Annelise on backstage. We can use it, of course, minimum 25 gauge cannula. So you can use it, the BioNutriLift cannula. This is derived from soft fill, from our friend Sandrine Seban. Hi, Sandrine. But you can use it soft fill, okay, but you can use it TSK with 25. And I told you, Annelise, we can use it to 22. The 22, so the black one with 70 lengths. And when I use the 20, I use this entry point and I will do all the length of the mandibular lines into path through the mandibular ligament and path through the encoche of the mentonnier. So that's a good question. So 25, 22, 23, but prefer 25, 22.
Okay, fantastic. And just before I leave you, I do have one final question I'd like to ask. We've got a lot of questions coming in. And this one is from Felipe Hernandez in Mexico. And his question is, can you combine Botox at the masseter with enhancement filler?
Yeah, you can combine. But look, if you have some bruxism or some deficit of the masseter on the hypertrophy area or in the male patient, if I do my toxin, 25 units of Xeomin Bocuture each 3-part, is the same pattern that I did with my art filler volume. But I don't want to decrease my mandible. I want to increase. So it's okay for the female patient, but not with my male plan treatment. But you can do it, but maybe not in the same session.
Okay, thank you very much for that. And again, keep in sending those questions. We have about 20 minutes left.
Yeah. I'm on time, first time. So now we will do an approach for the nasolabial fold because we did it corner of the mouth. We can do this approach. Okay, 2 options. We can do a blanching technique, art filler fine lines, needles in the technique barreau de chaise, barreau d'échelle, so be perpendicular, or we do the consensus new approach from 10 years with the cannula approach. So my entry point will be there, 1, 2, and I will use art filler universal. Art filler universal with my cannula up 25. Ça va, Pierre? So you can stretch the skin with your opposite aid, rotate, open the mouth, ouvre la bouche, to avoid the modulus strength and the contraction. What I want to do, I don't want to fulfill, sorry, you don't see, I don't want to fulfill the nasolabial force. What I want to do, I just want to give a little bit light. And I will use the mechanic approach of my cannula. I inject a few quantity. Don't forget that we have 0.2 lidocaine. And I will pass through. Look at the tip of my cannula. I pass through, I go behind, I go below, I go front. And sometimes I don't inject some fillers, but I do like a dissection. This is our friend Philippe Questemont that learned that with the tunnelization. And thank you, Philippe. I use this technique, and you can look at this, rotate, pass through. I don't inject, and I do a lot of chenal, don't say in English, a lot of tunnels, a lot of way, and I will inject. My friends Valérie Philippon told me to look with this same entry point. This is the entry point of my biometry lips. If we seen that we just have to give a few projections of the profiloplasty, remember the chin line, we just want to do a few projections and a balance between the infratip, the upper lips, the lower lips, and the pogonion, we will inject few quantity of the universal. Look at my pistol, my syringe. I will inject 0.05 on the white lip. I finish to do my nasolabial fold.
Okay, I'll just jump in if I may. We have a question still in relation to the Botox question that was asked a little earlier. This question comes from Dr. Ivath Duz, again from Mexico.
Wow.
And the question here is, if you do the Botox and then the filler, can you do them either the same day or should you wait between the sessions?
Wait, in an aesthetic procedure, you never hurry. So wait 2 weeks.
2 weeks?
2 weeks between the maximum potential effect of my toxin.
Okay. And we have another question here. Why don't you inject the needle in the nasal cavity, the nasal to nasolabial groove?
With the needle?
With the needle, because
Because
some
now
doctors say that it would be less painful or less aggressive for the patient.
No. It was. T'as fait mal, la dernière chose? No, it's for Pierre, it's painless, but no, because of the risk of the artérial labial. Remember the anatomy. You know, you have hop, artère carotide, système interne externe, hop, external system, and we have this arterial, and there is 33% of variation. So maybe it's here on Pierre, maybe it's here on the Xavier, and maybe it will here with Julian. So how can we do? I'm really not sure. Maybe it's here, and maybe it's deeper, and this is a really, how to say, curve arterial. So if you inject right here, superficial ear or more deeper ear, you can pass through the endothelium of the arteria. So this is really dangerous.
Okay.
And this is the necrosis risk, and this is one of the dangerous area, the 3 dangerous area for the arteria. Really ear, really ear,
Okay,
really
and
ear.
we actually do have a question on that, a question from Portugal. So that would mean that you never inject in that area because of those risks? The question from Portugal is, would you ever inject into that area or never because it's too risky?
Yeah, I inject with my cannula approach, but you can do it with the needle approach. I told you, you want to see. But we will do after with the fine lines. But okay, I answer you to Portugal because I love Portugal.
So you're very lucky, Portugal, you
Hello,
get a
Tanya.
special answer.
Hello, Tanya. Hello, Tanya. So your doctors are, how to say in English? On point. So look, so I answer to you with the needle approach, but you will be really superficial with the outfield of fine lines in the blanching technique. Our friends Patrick Michels from Switzerland, hi Patrick, and he learned us to do the blanching technique. How we do? Stretch the skin, use a fluid, but a cohesive product, stretch the skin, broke your whistles, and do with the 10 or 12 degrees with an anterograde approach and push your product. This is the less risky approach to do and to finish in a superficial layer your nasolabial groove, not in another way. Don't use universal, don't use volume, and be really gentle, few quantity. It will be maximum 0.15. You see the bleeding because we are on the junction, on the papillar dermis, and you see the blanching effect. It will last maximum 20 minutes. But we will see on the forehead. But it's okay. You see in it, Portugal.
Okay, thank you very much for that answer. Please do keep on sending those questions in. We have about 15 minutes left, so I better leave you to finish off the procedure.
Yeah. I need it. So
I'll be back shortly.
now we will erase the hollow of the regard. What I will use? I will use a cannula approach. I will be under the ORL. I will feel the double click under the orbicularis retaining ligament. And what I want to do, you see the bleeding because of the dermal. You see the bleeding, totally normal. I'm on the good layer. No, we don't want to. Okay. I will do the orbicularis oris retaining ligament approach with a universal cannula approach, of course, because this is one of the most dangerous area. Entry point, 23. Gauge needle, where you are. And you see the bleeding because of the blanching technique, totally normal. What you see, we will inject here. I pinch the skin, my entry point. Voila. And I will use my universal because why? I need medium elastic product to pass. Est-ce que vous voyez bien? You pass through the ORL. So be perpendicular to the skin. Pinch the skin. Ouais, je sais que vous voyez un peu moins. Up and feel. You can hear. Tu l'as entendu, tu l'as senti, Pierre? The patient feel it and see when I move. Maybe I'm a little bit too superficial. Voila. And see, when I move the body of my syringe, you don't see anymore the tip of my cannula. So I really want to do a secure and safe approach with the cannula and to avoid this groove, avoid the sustarsal hold. I want to not fulfill, but to enhance. This is a lightning approach in a male patient. But remember, I don't want to inject the apex of the cheekbones because I don't want to feminize my patient. I'm really deep. I'm contact to the bones. I'm on the lateral part of the medial fat pad, and I correct my shadow. I inject few quantity of retrotracing. At the beginning, protect with your opposite hand, protect the ocular globe. Look, when I move the body and the beginning of my cannula, you don't see the tip of my cannula. I'm on the good layer, I'm deep. Inject, finally, 0.4.
Excuse me, doctor. We have a question here from Brazil. Thank you for your question. It's just to sum up and resume pretty much what you've done so far. So they say that you apply 0.6 to the mentalis, 0.6 to the masseter, and 0.6 in a fan pattern to the jawline. Is that correct?
Yeah. Yeah, 0.6, 0.6. And the last
With
last number?
0.6 to the jawline in a fan pattern.
Yeah, with universal. You're right.
Okay.
Look, this is the sustarsal hole. This is the most important because it will give the light. So you see, in this patient, I don't choose to inject directly. Okay, I stop it. I don't use to inject directly the malar, the tear through, because we don't need it. Because we treat the tear through and the laxity with what? With the nanosoft.
Okay, thank you very much. So that's 0.6, 0.6, 0.6 to the mentalis, the masseter, and the jawline in a fan pattern. So thank you very much for that. We have a question here from Sweden. So thank you again for your question. So you were just talking about the temporal region, saying that it's a risky area. Why is the temporal area quite risky?
Quite risky is the arterial risk. So when you inject the temples, so we really do the full face tonight. Wow, you're in a good shape. So in the temporal area, veins do the Valsalva technique, doing the decubitus with your patient with some tissue, and you see after the veins, so you avoid the veins. The facial nerves, the 7, it's okay. We don't see it, so it's really deep. Glands, there is no, but arterial risk. We have the communication with the interior carotid system with the ATS, with the superficial temporal arteria. So the superficial temporal arteria is sometimes going directly to the carotid and is going to, j'ai plus de crayon. And it's going like that. So this is the arterial risk. Look, you see your arteria. So maybe it's there, but we don't see variation anatomic, you remember. So if you use a needle, but I don't recommend to use needles, put 2 fingers and 2 fingers before the tragus, the tragus, and you don't to inject on this face, on this part. So this part is more safer. Okay? But my approach, if you do a needle, the consensus is to go like that. You go here, you feel the temporal crest, and then you feel the hole, and then you inject on this part. Never go on the shutdown gun technique on the concavity. But my approach is with the cannula, and with the cannula, what I do like that. With this entry point, superior border of the zygomatic arc, and I will spread my product between the 2 fascia. But we don't do this on the patient. I want to show you the enhance of the regard with my Nanosoft. Just look, this is a good option for the patient. You see it with Valérie last month. Stretch the skin, do the papilla, do an anterograde pressure, go under the lower eyelid, and enhance with an intradermal injection. Look at this papilla, this is fantastic. Yeah. And during 24 hours, the NCTF and the 59 vitamins and the hyaluronic free acid will spread it in my area. In Pierre, we really need to give some elasticity, some power of this region. Combien de minutes, Peter?
We have 10 minutes left, and it's perfect that you're moving on to this area now because we actually have a question on the suborbiter area. So this is a question from Chile, thank you very much, from Dr. David Bendov. And he's wondering, why don't you use an anesthetic like when we're at the dentist's when you're working at the suborbital area?
On the which area?
Suborbiter.
Suborbital? Ah, no, I never do trochancular anesthesia. Because of what? Because I'm gentle, because I'm slow, I use cannula, there is lidocaine in my product, and I do anesthesia by topic, by cream. So you really don't need trochancular. We never did it trochancular anymore for any procedures.
Okay, thank you very much. And before I leave you, we have one final question. This is from Vana in Bulgaria. Thank you very much. Which filler is more suitable for the forehead, the fine lines or universal?
Wow, you are really synchronized. Yeah, you're perfect. Look, the right answer in action. Of course, what do you think, Peter?
I think it's perfect timing.
Yeah. But no, what about the fillers? It's about fine lines because I need to spread and to use the cohesivity of my products. So look, you remember I did the blanching on the nasolabial groove, so I will use the thumb technique. So stretch the skin, broke your whistle, use the cohesivity of the fine lines, and do with the needle technique. See, I spread it on the extracellular matrix with my fine lines. So this is really suitable after 2 or 4 weeks after my toxin.
Okay, fantastic. Thank you very much for that. And that's for you, Vana, in Bulgaria. So we do have just under 10 minutes left, so I'll leave you to it to finish off. Thank you.
Il nous reste encore 10 minutes, c'est ça? C'est super because I have a lot of time and I hope you really see all the techniques. So to ask to Bulgaria, yeah, look, I use my blanching technique. I do an anterograde technique with an entry point, with an entry angles of 10 to 12 degrees. You see the bleeding, totally normal because I'm targeting the papillar dermis. I push my needle, give a good support of your injectable end, broke your whistles, and inject the angles to really achieve the superficial injection, because when we say blanching, we want to inject in the superficial dermis. It's really targeting. It's really difficult. But sometimes, okay, I'm on the medium dermis or I'm superficial, come on. You see? And for the first time, I'm in an economist approach because I only inject few quantity to reshape all this part. I think we will have time. What to do? Maybe to finish and to see again in the last 10 minutes the masseter on this part. Huh? What do you think? Because finally, I do the forehead with the blanching. We do the sustarsal hole and we pass through the ORL. We enhance the regard. So yeah, let's do the masseter because it was a lot of question about it. And this is really the targeting point of my male approach. So what I will use The same syringe, remember, I was using half syringe of art filler volume on the masseter, contact to the muscle, into the muscle, opposite. On passe sur le côté opposé. Alors, serre, fort, fort, fort. Do the strength of your muscle. So I will inject. Vous voyez bien? Super. And hop, I'm perpendicular. Là, tu as senti quelque chose. You felt it. Yeah, you felt it because I path the muscle and now I'm contact to the periosteum. But that's good. Be perpendicular of the dermis plan, of the skin plan, yeah. And inject the first bolus of 0.2. Okay. I want to give you, remember, the triangular shape of my male face, lower face. So what I used to talk about verticality because I inject the metaface and I want to give verticality. I want to give angles. I don't want to give curves. Okay. Resserre la mâchoire. Relax. I will inject here. Before of the second layer with my universal, I do the plasticity, I do the massage of my product, few seconds. Maybe you can sit down, tu peux t'asseoir, voir un petit peu. We don't have finished this injection, but look, if I stop with my triboli of my art filler volume, you see the difference? I need more here. And you see the laxity? What about the tension? It's really tense. Look, we need more.
We have a very quick
Très, très
question
beau, ça
here.
fait très, très bien.
This is a question from Kuwait, from Dr. Lakhdar. Thank you for your question. And seeing as you were just moving on to the left-hand side of the face, do you have different techniques for the left as opposed to the right? Or is it the same technique for both sides?
Same technique for both sides. No, repeat the question.
Yeah, so is it the same technique for the both sides, or is it different?
Yeah, the same technique.
Same technique.
Same technique, but come on, we have few minutes, so stay with us.
So it's the same technique, and I will be back in just a few short moments because we are running out of time. We have about 3 minutes left.
Because this is really important to see, once again, the masseter approach, the mandibular line and the masseter approach. So I will do my entry point, 23 gauge needle. Merci. 1 centimeter of the angle of the mandibular. And I will inject 0.6 of universal. With the cannula 25. Stretch the skin, rotate the body of your syringe, and do the amplification. In this same entry point, if you need to reshape the oval too, you can go easily. In Pierre, 40 years old, it's okay, but in male patient 50 years, you can go look at my entry points, and we can go on the lateral border or the inferior border of the mandibular line. But now I'm targeting more the masseter. Okay, so I do few retrotracing. You remember how much I did? 0.6. Tu sens quelque chose? Wow, no, so painless procedure. At what was the most painful procedure? Où est-ce que tu as senti le plus? On the forehead for the blanching technique, of course. Maximum globulus corpulis, the fibres sensitive, sensitive fibers. So, of course, this is the skin, the dermis that hurts. Okay, I put 0.6. And you remember, I do in the way of the bionutri shape, I will mix and I will use some NCTF 135H2. Wow, what a full face approach. We do the third compartment, upper, lower, and mid face. Il me reste combien de minutes, Peter?
1 minute.
1 minute? So look, I really want to summarize my assessment because it's all about that. Beautification, masculinization, and plant treatment. Wap, vas-y, assieds-toi. What I did, finally, we did the third compartment. We did blanching technique. We enhanced the regard with the universal. We do the nanosoft. We enhance and give some projection and give some masculine strength with the masseter and the jawline. We point the chin. We inject gentle the nasolabial, and you look the difference with the shadow and the light, and look at the commissure too. Just 0.3 of universal with a needle approach. Look, we need it here, and of course, look at the shadow too. We need to erase this shadow.
Okay, so I just have one very quick question I would like to ask you. This is a question that we have from Dr. Kenningham from Wales in the United Kingdom, so thank you for that. The question is, do you get much suborbital edema from using nanoneedles with NCTF around the tear-through area?
No, some edema? No, you told to your patient 24 hours of the papilla, but no edema, no bruising. This is the definition of the nanosoft. This is definitely better than with the needle. Look at your reaction. What do you think, Pierre?
Yeah, good.
You recognize you?
Yes, of course, I do.
And what do you think about your chin? Because you was afraid maybe I put and I change your shape?
No, that's good. That's nice. Very nice.
That's really
I like
nice.
it.
That give you a strong attitude.
Yes, true.
But always you and no different.
Yeah, exactly. Oui, pardon. Oui, no, that's very good. That's really what I expected. Very soft, gentle, and it is me, so that's perfect.
Yeah, really, the jawline, this is really impacting. Look at the profile, stay like that. You see? We really do this angle, the verticality. This is really great. And look at the chin and the profiloplasty too. Really, really good.
And we do have one final question, and it's more a general question. This is from Dr. Cohen from France, so thank you again for your question. And the question is, what is the usual price for this type of procedure?
Oh, yeah. The price, depending, because we do the full face approach, but with the long-lasting result of my art filler volume or my art filler universal, 18, maximum 44 months. So some area are fixed from 1 year and a half, so it's good. But what I do 1, 2, 3, 4, 5. I do 6 syringe, but it will be 6 syringe for a full face approach from 1 year and a half, and it's about between, depends of your region, of your country, but between 1,050 and 500 euros to 2,000 euros. But you can do it in the 4 session at 500 euro each 3 or 4 weeks or 4 months. So it's really suitable. It's really, it makes sense.
So quite long-lasting results then.
Yeah, with the long-lasting result, it makes sense. And if we divide the 4 sessions each time with 1 to 2 syringe, and we will do the lower part, then we do the regard, then we do the surface treatment with the 2 syringe of fine lines, and then we finalize the touch with the chin or with the perioral area. So it makes sense, and it makes sense to our job, to our occupation, because it's more than to fulfill wrinkles, it's to give self-esteem of the patient.
Exactly right. Thank you very much for your time, and thank you to all of our viewers who have been watching this evening. I would just like to thank you once again, Doctor, and thank you to Pierre, our patient. And just one final note, if any of you would like to join us for our next session, it will be on the 19th of November, and that session will be in French. So once again, thank you all for joining us from wherever you are in the world. We had a lot of people connecting in from Russia, from South Africa, through to South America. I can't name all of you, so good evening or good morning or good day to wherever you are, and thank you once again.